when we're talking about lasers and using energy-based devices, this is an important slide. This really exemplifies that there are patients who do get hyperpigmentation, and some of that is dependent on settings. Some of that's depending on the number of passes. Sometimes that's pulse stacking. So Michelle, if you saw a patient like this in the more proximal area of the arm, and they come into you and this pattern type of appearance has been there for a little bit, how would you approach this?
So a number of ways. Of course, I'd like to know what device was used, if they had any scarring. I'd want to know how long ago they had this. I often start with topicals. I then advance to doing something like chemical peels. And then ultimately I would use maybe one of the fractionated devices, either something like a Clear and Brilliant, or in certain patients, I will use a Fractional, again, echoing what was said prior about really, really low density, which is so critical. But that's my approach to these patients, and they typically do well. I think this is a patient that wouldn't make me quite anxious in the office. I think we could have really good success with a patient like this.
One of the very difficult things in seeing these patients is you really have no sense of how deep the injury was or what things looked like a couple days later. So, I've asked my staff to not only try to get records about when it occurred and what they tried as far as treatment, what specific device was used in terms of wavelength, what settings were used, perhaps how many passes were used, but I actually really like to get pictures as well. So, are there tips that you give your staff, Michelle, or Omar or Jen, just to really try to get people who come in to have all the information that you're going to need in that type of setting to best help them?
Yeah, we usually tell them upon consultation, if they say that they've had a burn, if we know that it was from a treatment at an outside spa or office, we ask them to bring in, to try to jot down the history, what they remember the recovery was like. So we know if there was blistering, that will give us an idea of like how deep, what was involved, to definitely to bring us prior notes, to let us know exactly what device was used. We definitely try to collect as much information as we can, because that definitely gives us some strong guidance as to what treatments we can proceed with.
So our good friend and president of the American Society of Dermatologic Surgery, Matt Avram, has published some really important information, and he being not only in charge of the Wellman and the whole fellowship program at MGH with Rox Anderson, but he as a lawyer has really an understanding of the litigious nature of some of these conditions. I just want to back up and, Omar, if you can talk about specifically when you see a patient like this and the injury was caused by, according to Matt's article, most frequently things like IPL and hair removal, and then you talk about using a modality that's similar in some respects. A patient just categorizes it as a laser and you're using that to treat it. How does the conversation go?
Yeah, that's a great question, Joel. It is a difficult conversation to have, particularly because the patients come into you, they're already upset, and I echo 100% what Michelle was saying. Oftentimes you want to gather as much information as you possibly can so that you can go about treating this in an educated way, because the minute you as a dermatologist touch this complication or start treating it, it now becomes yours, and the patient's going to hang everything that happens going forward on you. So typically with this, you're 100% right. I would, as Jen and Michelle were saying, probably take a fractional approach, the non-ablative fractional approach to treating this hyperpigmentation. And oftentimes that's very alarming to the patient, because they're saying, wait a minute, this is what hurt me, and now you want to go ahead and use this device to treat it. And I think because Matt Avram is a lawyer, and he's been a good mentor to me, I've really taken to heart the value of having a nice extended patient consultation and a good informed consent process, where you're really explaining to them, as Jen kind of said, look, we're going to use the same device, but we're going to be much more conservative. We're going to dial the settings down. So it's really a completely different kind of process. And we're going to follow you up, make sure things heal well. And I think when you just sit and spend a little time with that patient, and then you do the treatment, and you follow them up, they're oftentimes, once they see that improvement, you've got a patient for life and somebody that's going to go out and tell their friends about you and send them to you.
That's great. So in terms of, Jen, the combination approach, we're maybe thinking of using non-ablative fractionals. In some cases, we may use focal ablative, in certain areas where there's pigment loss and you're trying to repigment along with the lattice. In terms of other things that you throw into the mix, sometimes we're doing combination of procedures, topicals, and sunscreen. So, what advice would you give this patient in terms of after the procedure, and what combinations would you use?
I, like my colleagues, exactly the same. We have a long conversation, and I also find out if they're involved in a litigation, because oftentimes we document the case, and the plaintiff's lawyer, if they're in an active litigation, the plaintiff's lawyer will not want you to treat. So that is one thing we do. We do document photos, and we view their history of what happened. In a selfie culture, the patient often has so many photos every single day, right after, leading up to when they saw you. And then I find out if they're involved in a litigation and if their counsel wants them treated at all, because sometimes you're not even able to initiate treatment. But if they are able to initiate treatment, we can get them better so much faster, utilizing, as long as there's erythema, I actually treat the erythema first. And once the erythema is resolved with every other week LEDs or even weekly LEDs and anti-inflammatories, I will start treating with a combination of non-ablative. And if the patient is super concerned or terrified, we just do a 1 centimeter test area and bring them back in 2 weeks and then expand the area that way. And if there is an area of depigmentation that we're concerned is going to be permanent or is scarred, then we will consider the ablative fractional in super low density. And again, in these patients, they're so scared of doing an ablative device. So we'll just do a 1 centimeter test, treat that tiny area. And once they see that there's progress, they're usually really thrilled and on board for proceeding with the full treatment. Like I said, in New York City, we're really a referral center for problems. And from lasers to these energy devices, I see quite a lot of pigmentary disturbance and problems that have occurred. And so it's not just the lasers, which we've talked a lot about, but it's these energy devices and even cooling. We know that cooling can cause hypo or hyperpigmentation in darker skin tones. And while rare, we do see problems. Here is a patient, type 5 skin, who has hyperpigmentation, which was temporary from cryolipolysis. And I have seen this from ultrasound-based devices as well. So therapy, microfocus ultrasound, it's very rare. And it was more common when these devices were first introduced, probably about 10 years ago, but we have seen this. And there's a new soft wave device. It's also focused ultrasound, but it's a little more superficial. And in their initial study, 1/3 of the patients were darker skin type. But I imagine once this device gets out in the community that we're going to see more of this. And we're going to see it, especially when people start using this on the body, because these energy devices on the body can cause hypo and hyperpigmentation. So this is an invasive ODA, and these do respond really nicely to Q-switch lasers. I still typically use the Q-switch Alexandrite laser, and any hypopigmentation that I get is typically temporary. It usually resolves. It can take several months, but it does usually resolve and blend quite nicely. So these can be really satisfying and life-changing for the patient to treat. These are really, really great patients to treat if they would like to treat their birthmark.
So Michelle and Omar, for these patients, I think, we see them, it's quite rare, but in centers where you have a lot of lasers and a lot of devices, we tend to see these people. And again, we try to blend some of these things. So I often treat this with a kind of a combination of a Q-switch 532 and a Q-switch 1064. With the 532, you get a little bit of whitening, and then the 1064. How do you guys approach this?
I have a collection of these patients that are skin type, probably 5, closer to 6. And I usually use a Q-switch 1064 in those patients. It takes a lot longer. And so I always tell them it's an exercise in patience, but we'll get there. But that's typically what they tolerate best. In the past, when I've tried like 532 or even a Ruby in those patients, they tend to get some hyperpigmentation that in my patients, they found that to be more troubling. So I find that it's better for me to use the Q-switch 1064 and just, do as many treatments as they can tolerate. They tend to do well all the time.
So Omar, what type of tips do you have? A lot of us have seen these patients, and I think it's important to really underscore that when it has this type of proximity to the eye, having an internal stainless steel shield is essential. Brian Weisman in Dermatologic Surgery wrote a very nice editorial on this. Do you have any points for this type of condition?
Yeah, Joel, that's a great point. One tip I would say, just in general with ethnic or skin of color patients is we can't look at them as all homogenous. So, certainly I think in an Asian patient with a nevus of OTA, you have a few different choices, like the Q-switch 755 that Jen used, or even kind of considering a Q-switch 532. But if this were a Black or South Asian patient, I'd probably lean more heavily on just using the 1064, just because that window of safety with hitting the melanin and not disrupting the epidermal melanin is a little more narrow in those darker skin types. The eye safety is such an important point, not just with ethnic patients, but all our patients when we're treating things around the eye. Remember, the eye, the retina has melanin pigment in there, and the human body, the melanin doesn't know where, the laser doesn't know that I'm supposed to avoid the melanin in the eye. So if it's within the orbital rim and outside of the, and you can't get it on the bony orbit, 100% you want to consider putting in an eye shield just to protect the patient. This is something easy. Any dermatologist should be able to do this. Pretty straightforward. Takes 5 minutes to do. Usually I'll check their pupillary response before and after. That's a little pearl I learned from a colleague of mine, right before and after, just to make sure that nothing happened with the laser. But certainly you can treat with an eye shield all the way up to the lash margin. You do want to be a little careful because you won't get permanent hair removal, but even with the Q-switch device, you can get temporary hair removal. So be aware of the brow and the eyelashes as well.
Mm-hmm.
This is a 38-year-old gentleman who is of Egyptian descent. He's actually my lead esthetician's husband. And we have a concern when we see people of Middle Eastern descent that they could have something called paradoxical hair growth. And Omar has really written a lot about this, and I'll have you talk about this. But in this particular circumstance, we used a device called the Cocoon Prime Lace. It's a laser from Spain. It's an interesting laser because you can use 4 different wavelengths. So the 810 diode has the opportunity to have a very big spot size. You can treat the back in about 8 minutes. It's very, very quick. It's very efficient per treatment. You can see this is only 3 treatment sessions, and you can see the dates here along the way. This is not something that has any significant pain, but what's also interesting is you can get this platform where it has also 810 with 940 and with 1060. And the ability to integrate these different wavelengths, especially for darker skin type, can cut down on the potential for that paradoxical hair growth. But in addition to that, really from a safety perspective, you can go up in treating darker skin types. So Omar, I'll have you comment on that.
Yeah, so interesting, Joel, since you're such a master of the literature, Eric Bernstein actually published a case of paradoxical hypertrichosis on the back of a Caucasian male. However, that's not the typical clinical scenario. With paradoxical hypertrichosis, the condition is basically what the name says, and oftentimes it's when you take these small little vellus hairs, particularly in women that have hirsutism, that are looking to treat the sideburn or the jawline area, and particularly in women that are Mediterranean, Middle Eastern, South Asian heritage, where you're using a laser, and oftentimes you're using a 1064, which has a little lower absorbance, and you're being a little more conservative. So the working mechanism by which paradoxical hypertrichosis occurs is that you're actually using, you're doing a sub-therapeutic treatment, and the amount of heat that you're generating is actually taking these vellus hairs and converting them into thicker terminal hairs. So rather than killing the hair follicle, you're actually helping them differentiate into to terminal hairs, and those are larger, and oftentimes these are a little more refractory to treatment. And so since we talked about Matt Avram, and you know, and as a lawyer, he really stresses the importance of informed consent. This is something that I review with every patient, but in particular, when you're treating somebody with hirsutism, or you're trying to treat something on the chin, oftentimes they'll ask about this area on the sideburn and jawline, and I try to discourage them or try to put them on a topical, something like Vanica, that can inhibit the hair growth cycle. But if they persist on wanting to proceed with it, I let them know about this risk, and that it's, you know, highest in their patient subtype.
So this is only 3 treatment sessions, but I think it underscores the amount of improvement that you can see in 3 treatment sessions. And obviously we recommend more than that. You can see this last picture was recent, but it also shows you an area that there's a little bit of area that's left in terms of hair. And I think that's important because, you know, when you're taking meticulous care of patients, things are in different cycles. You may actually not hit something with the same amount of passes, and we tend to be careful in darker skin types. And this is completely normal to have an area that was just missed or didn't respond as well. And that's why we do more sessions for this. So, you know, Michelle, how do you really counsel patients when they come in and they may be disappointed because one area didn't respond?
Well, typically for all of my patients of color, I always, I let them know that a better way to describe this might be laser hair reduction instead of laser hair removal, that we're not going for 100% removal. And I let them know about this particular phenomenon that can happen. And so I counsel in the beginning, and I really try to manage expectations early on. And I note it once I see it early on. So every patient that I treat, I manage their expectations in that way. So I really haven't had much difficulty with it.
So Jen, this is an Asian patient, and you can see she has rolling acne scars in the temple. I treated her, this is 2 treatments, and with the Fractional, the Cyton 2940 Fractional. You know, in terms of these patients, we talked about using the RF microneedling devices like Genius, and a lot of times I'll integrate that with very focal treatment of a fractional ablative erbium, more so than a CO2. You know, what's your approach and thoughts on this type of condition?
I do really like fractional. I'm sorry, I do like microneedling with radio frequency, but I will say these devices are not all the same in the way the tip is configured. We keep several of these in the office, and some of them are a lot more forgiving in darker skin types than others. And the ones that specifically have bipolar RF paired to the lateral edge of the tip, or there is one device that we have that's actually paired to the surface plate, you can see quite a number of pigmentary disturbances if that's the type of RF needling device you're using. So I'll say it's a fantastic approach and I love using it, but I'm really speaking about those that are insulated and limit the energy delivery just to the tip in the deep dermis. And that would be probably my first approach in this patient, would be to do a series of those along with hyperdilute filler or even PRP if needed to enhance the results of the energy.
What about you, Omar?
Yeah, I think I feel the same way as Jen. I think, you know, I would probably say my go-to would have been RF microneedling, and I like the Genius device. That's the one I use most in my office. But you know, I think the beauty of this is you're showing a nice improvement with a ablative fractional approach, and you probably did it with low density and were cautious with your settings. And so certainly you can use ablative in these ethnic and skin of color patients, and you just have to pay attention to your parameters. And I think as was echoed before, you know, considering the test spot, you know, that's so key. You know, you can always treat a small area and have them gain confidence in you, and then come back and treat the whole thing.
Michelle, as a fellow Mohs surgeon, and a lot of us, we do skin cancer surgery on a regular basis. This is a woman who is Latino descent, and she had ultraviolet treatments for acne as a kid in many sessions. And she ended up having at a relatively young age, in her late 30s, a squamous cell on her cheek. I did a linear closure in June, and then in September, you know, she was concerned about the post-inflammatory hyperpigmentation that she had along the suture line. she's a nurse at one of the hospitals that I work at. And, you know, it's tough. I don't want somebody walking around saying, you know, look at the surgery Cohen did. And, you know, and somebody's saying, oh, it doesn't look so great. And, you know, this is a very challenging circumstance where you don't want to make things worse, but you also have a time frame to make things better. And I think a lot of us, with the important work of Rox Anderson and others about early intervention scar therapy, and then some of the work that Dave Ozog did with Ron Moy about treating scars very, very quickly, in some cases, you know, immediately. You know, so I waited a couple months, made sure she tried to be diligent over the summer with sunscreen, which is really difficult for people to do. And then I used an ablative fractional erbium, very low density over a couple sessions. And I just wanted your input on how you handle this with your Mohs surgery patients who have darker skin type on the face, where, you know, they have post-inflammatory hyperpigmentation in the suture line, and the things that you can do to treat that, and the things you can do to counsel them about really diligent sun protection.
Yes. So I take a similar approach, and a lot of my patients are even darker skinned than her. So even if it's a Mohs procedure or some other facial surgery that I've done and we're concerned about pore scarring, of course, I talk about sunscreen. I will use some of the silicone-based scar gels. And then I will use non-ablative fractional laser as early as maybe even 4 to 6 weeks, depending on my level of concern. And I find that the earlier I use it, the better that they do. Again, focusing on, you know, relatively low energy, but especially low density, which we've all spoken about again and again and again, which is so critical with these patients. But that's my approach with them. I find that lasering earlier on while while the scar is remodeling usually works a lot better. And I counsel them on that on our very first visit. And patients tend to do quite well.
So Omar, I'm going to ask you, you know, in terms of this, nowadays, I think I would approach this as a first start, as Michelle indicated, with a non-fractional laser. I really like the Thulium 1927. I have the Lace Ultra. I would zip over this whole area. I would improve probably the lentigines that she has as well in the circumstance. And then it's interesting, the approval for the non-ablative fractional 1927 lasers include actinic keratoses. So in somebody who's had a squamous cell, I think that really underscores the fact that there's a laser that traditionally we think of as a cosmetic laser. However, it can actually be helpful for actinic keratoses. And the Lace Ultra at 20 watts and the Moxie at 20 watts, and then you guys referred to Clear and Brilliant or the Dual, you know, there's some choices here. So how would you approach this patient?
Yeah, Joel, I would do exactly as you said. So, you know, I think the Laser MD Ultra, the Moxie, the Solta devices, those are all great options. As you mentioned, Roy Geronimus did a wonderful study showing that, you know, series of 1927 treatments doesn't reduce the incidence of actinic keratoses. And so, you know, I think this all goes back to the interesting observation that fractional treatments really have this unique ability to bring things back to normal. Whether it's a burn scar, an acne scar, or hyperpigmentation, it has an injury pattern that really stimulates the body to restore things back to the way they were. So, you know, I think we all have the same kind of approach. I think, you know, the most important thing is paying attention to the parameters, knowing your device really well, and understanding your patient. And I think Michelle was talking about, you know, understanding your patient's background. And, you know, there are so many people with mixed races now. So, you know, questioning what kind of Fitzpatrick type, how they react to sunlight, how they react to an acne lesion. These are all things that are important to keep in mind.
So Jen, and we'll give you the last word in terms of sort of the approach from a topical perspective to this. So nowadays with the pandemic, I don't think we would see somebody who had some sort of post-inflammatory hyperpigmentation to this degree because everybody's wearing masks so much. However, you know, I think it's important that we also realized during this course of things that the importance of blue light on stimulating pigmentation. And we did a scientifically speaking with the woman, Dr. Teresa Michelle, who runs the FDA sunscreen division, as well as Steve Wang, who's written a lot about sunscreens, including a textbook. And I think it's really essential to point out that even though people use zinc and titanium it doesn't cover blue light unless it's actually not rubbed in. It has to be physically opaque. And honestly, I actually ski like that. It looks like I'm wearing toothpaste when I ski because I have so much zinc on my face. And my wife and everybody else makes fun of me. But how do you caution this patient? I would tell this patient, hey, you need sunscreen that has iron oxide protection, as well as zinc and titanium when you're outdoors in general. And in addition to that, in the morning, I'd like you to use something that's probably a vitamin C type of product or a cysteamine short contact, 15 minutes while you're having your cup of coffee. And at night, maybe a retinoid, and for a short period of time, have a little hydroquinone in that. So what would you do?
It's funny, I actually would treat this patient as soon as the sutures come out, and I would use these low energy, low density lasers right away. And there have been countless studies on this. And then I would use actually some less irritating topicals in the patient. I have them put a drop of dark concealer in their sunscreen to blend it, especially if they have darker skin types. So those sunscreens that you alluded to that have the best photo protection are often a nightmare in darker skin types, leaving this cast. So I actually have them take really dark concealer and put it into mask some of the zinc, titanium, iron oxides in the sunscreens. And then I'll use some of the less irritating topicals in between, like the vitamin C, blends with THC ascorbate. I'll use kojic acid, really low level kojic acid, arbutin, licorice, these blends that are much less irritating and easier to tolerate. And the other option is physically covering it with those scar sheets, which we've already mentioned. The patient can actually physically put just a tiny silicone sheet on the scar to physically cover it, or use the sunscreen techniques that we've talked about, along with those low level lasers at monthly intervals.
So my go-to sunscreen for type 3 plus all the way through 6 has really become the Revision True Physical, that not only has high concentration zinc and titanium, but it does have THD ascorbate, and importantly, it has iron oxide. And I find that to be really helpful right now for patients who have melasma. They may not be spending a lot of time outside, but they're certainly spending a lot of time in front of their computer screens, as our viewers are watching this segment. So I'd like to thank all of you guys for joining us and your hard work in putting this together. This is an extremely important segment about treating patients with darker skin type, using procedures and understanding the things that can go wrong, and how we oftentimes use procedures and a combination of different things like laser assisted drug delivery to make things better. So thank you very much.